Joe will be speaking on nicotine withdrawal and aggression. So I'd like to welcome Dr. Roger Joe.
Okay. Thank you, everyone. The presentation today, we're going to be talking about nicotine withdrawal and its relationship to aggression in a community hospital. I would like to thank a few of the other research assistants and helpers I have. Dr. Plikova, if she's in the audience, I want to say thank you to Dr. Plikova and Dr. Miramoto, who's been a great help in the development of this research study. Okay, so we started off this research idea with the development of the nicotine research idea. We wanted to develop methods to reduce seclusion and restraints on the unit. And we also were looking at a need for a hospital-wide standardized protocol to address nicotine withdrawal. As we already know, a lot of hospitals are going to non-smoking facilities, and there's also a push these days to just not include the indoor facility of the hospital, but also the surrounding hospital grounds. So there's a great need to manage nicotine withdrawal on the facility. We also want to improve patient satisfaction and reduce overall admission costs. So these were some of the ideas behind this research project. I guess one of the big initiators of this idea was Dr. Durst, who's no longer with us and has moved on. But she came to me a few years ago interested in reducing aggression on the hospital units. There were quite a number of seclusion restraints on a daily basis, and we tried to find ways to reduce that, reduce injury to staff, reduce injury to physicians during these incidents. So that's one of the reasons why I got involved. Dr. Plikova at the time was interested in nicotine withdrawal and substance withdrawal, including opiates and alcohol. So this kind of all tied together, and in its infancy, we decided to come up with this research project. But it did take quite a bit of work. Wasn't easy, but we were able to move forward with the idea. And I guess on point number 3 here, some hospitals that have actually gone to where the full hospital is non-smoking, and that's why some places you'll see individuals walk across the street to smoke their cigarettes. So I think that's where things are headed these days. So this is definitely needed. And just want to go over some of the statistics here for smoking in the psychiatric populations. This is just an overview of a combination of a number of research studies having to do with psychiatric populations. There's a high cigarette smoking rate and a low quit rate exist among psychiatric populations. The research has shown that people with mental illness smoke to self-medicate their symptoms and illnesses. And also nicotine withdrawal has been shown to worsen psychiatric symptoms in smokers and increase the potential for illness relapse. And that last statement is mainly having to do with induction of the P450 system, mainly the 1A2. And a lot of the psychiatric medicines also go through that, and it's an inducer, so it ends up metabolizing your antipsychotics faster. Okay, so more statistics here. Smoking by prevalence and diagnosis. I think the important one here that's usually on the board exams is schizophrenia. One that's 62 to 90%. So there's a strong correlation here between schizophrenia and smoking. The other ones with the alcohol abuse, 93%. Major depression around 80%, 36 to 80%. So these numbers are almost all over 50%. So especially in a psychiatric hospital, there's going to be a large proportion of the inpatient population that are going to be smoking. Okay. I don't know if we can see this slide very well, but there was a research study done by Renee Poles, and this is one of their flow charts that they use to determine aggression and the heightened likelihood of assault on the unit. I don't know if we can see it very well. Can everybody see it? But they developed a two-prong approach to determining the likelihood of assault on a unit. One side of the equation was the patient, psychosis, nicotine addiction leading to agitation, paranoia, and sometimes the pathway that we've been looking at is the nicotine addiction to withdrawal, to agitation, to the heightened likelihood of assault. That would be this pathway here: patient, nicotine addiction, withdrawal, agitation, heightened likelihood of assault. And we're also looking at the other component of this model here, which is based on the staff response here, and that's the recognition of psychosis to nicotine withdrawal, which lessens violence. So those are the two pathways we're looking at influencing to see if we can get a handle on this heightened likelihood of assault on the unit. I guess in this study, they actually they had a group of patients, and they actually looked at where the staff had a supply of large quantity of cigarettes, and they would hand them out to the psychiatric patients in a locked psychiatric ward and try to control violence that way. That's their premise on this study. But for our study, we're going to take the same model and just apply it a little differently. I don't think we're going to be having large quantities of cigarettes to hand out to the psychiatric population. Okay. And again, the flow chart goes nicotine dependence. We have an abstinence. The patients go into a nicotine withdrawal, and this is where we're going to apply our treatment. We're going to use our current treatment versus the experimental treatment, and then hopefully one will decrease agitation. But a lot of times, if without the experimental or the current treatment, there's going to be increased agitation. So let's go next. Okay, so what is the existing nicotine withdrawal process over at UPH Kino? So just a quick overview. We have patients that are brought into our emergency department, and they are determined to have psychiatric comorbidities that need to be admitted to UPH Kino. And the current nicotine withdrawal process is that the patient would have to request a nicotine patch for withdrawal, or they can request a PRN as needed, nicotine gun for withdrawal symptoms. There's really no rhyme or reason. It's basically the patient is requesting if they need any type of nicotine replacement. And then there's a transition to smoke-free facilities, hospital grounds, and units. So in this existing method, there's no standardization, pretty difficult to determine if we're even dosing correctly. So that's what was existing at the time. So we had to first develop a new nicotine withdrawal process. And this includes development of a new nicotine withdrawal protocol for the hospital and able to standardize the administration of nicotine withdrawal products. I don't think there's a nicotine replacement protocol out there. We tried to create one from someone else's previous work, but doesn't look like there's a CWA out there or similar nicotine withdrawal protocol. So we had to develop one, and it takes quite a bit of time to get these protocols put into place into the hospital system, because they have to go through approval through the forms committee. There's a big pharmacy has to go over it. There's a lot of evidence-based studies that go into these protocols, where you just don't say, I'm going to use a nicotine patch, and that would be the end of the story. So one of the big issues we had with coming up with this research study is that we couldn't withhold care for the control group access to nicotine withdrawal products. So basically that means in an ideal world, we would have one group of patients not given any nicotine withdrawal products, and the other group of patients given the nicotine withdrawal protocol and nicotine replacement products. That would be an ideal situation to see the true benefits of nicotine replacement. But since that's not possible, we decided to have two groups. The control group would be using the existing nicotine method, which is where the patient is able to request a patch or gum when they feel cravings. And then the experimental group, which will be given the new nicotine withdrawal protocol. Okay, so I think I missed a slide there, but one of the dosing methods that we dose nicotine patches along with gum, lozenges, is weight-based versus patient self-report. Patients can report their smoking habits. This seems to be pretty unreliable in the psychiatric population. And again, there's also the gold standard, which is cotinine levels. And these can vary greatly in the general population, depending on the content of nicotine in the cigarettes, secondhand smoke, and just poor patient reporting, and differences in the metabolism of nicotine. And then there's also the weight-based option, which is above or below 45 kilograms. So there's been quite a bit of discussion on which method to use. And we'll start off with the cotinine values. So this study was actually done, how well does self-reported smoking behavior compare to cotinine levels. So in one group, they're asked how many cigarettes do you smoke, and the other group, they done a urine test on their cotinine levels. Anything above 11.40 nanograms per milliliter cotinine is a positive, and then that's about 1 cigarette a day. So in this chart, you can see that 20 cigarettes a day, which is the right here, is about a pack. And then you have a huge variety of cotinine levels here, anywhere from 0 to about 400. So that's huge differential on the cotinine levels. But that's any patient that says I smoke 20 cigarettes a day, they can have definitely variable cotinine levels. So the best way to dose nicotine withdrawal is by the cotinine level. We can get an exact number, and then we can determine exactly how much milligrams of nicotine replacement they need. But I guess this test is about $10 a piece. So if I was to do the research study, an ideal situation, I probably would get a cotinine level on everyone and dose appropriately. But we're not able to do that. So we have two other options. We can go with the patient report or the weight-based option. And as shown in the last one, patient report, 1 pack of cigarettes can vary anywhere between 0 and 400 of cotinine on the test. So it's pretty unreliable on patient report. So we decided to just use the weight-based option. So if you're above 45 kilograms, you get a certain dose, which is the 21 milligram patch. And if you're below 45, you get the 14 milligram patch. And this is pretty safe dosing also, because the nicotine patches only probably give 40 to 50% of what a true smoker would be exposed to in nicotine values. Okay, and then was a big discussion about gum versus lozenges. So I think it came down to a cost. So a 4 milligram piece of Nicorette gum is about 43 cents a piece. 4 milligram nicotine commit lozenge is about 56 cents. So there's a slight discrepancy here of about 13 cents. But I guess when those pennies slowly add up in the hospital and to increase cost. So some of the things with the problems with the gum, even though it's cheaper, there's a lot of times there's a lot of improper usage. And this involves the method of using the gum. You're supposed to chew it until you get a tingly feeling in your mouth, and then you are supposed to park it and let the nicotine absorb in. And a lot of patients, especially in the psychiatric population, just keep chewing, or they swallow the gum, so it doesn't quite work out too well. Poor dentition, jaw problems are also some problems with the gum. The gum ends up being stuck to the wall under tables, anywhere else. So those are some of the disadvantages of having the gum. There's also been some research studies that compared the gum to the lozenge, and actually the lozenges have a better steady state, less variability in levels of nicotine. I guess the only, I guess one of the reasons why is that you put the lozenge in your mouth and you let it dissolve. The only reason you wouldn't get the nicotine in you is if you chewed on it and swallowed it, the lozenge that is. So one of the new things we have now is where in the past there was a lot of issues of just patch or gum and contraindications to using both. But there has actually been a new study that's been out that was a randomized placebo-controlled clinical trial of 5 smoking cessation pharmacotherapies. And in this study, they took placebo, they took Wellbutrin plus nicotine replacement, they did a patch alone, they did a patch with lozenges. And it turned out in this study that the nicotine patch plus the lozenge produced the greatest benefit relative to placebo for smoking cessation. So this is one of the reasons why in the protocol we decided to have a baseline for nicotine withdrawal, which is provided by the nicotine patch. And then there is as needed pure and gum or lozenge would be the ideal situation, but pure and gum as needed for breakthrough cravings. So let's take a look at some of the numbers here on this research study. So as we can see, if you use the patch alone, your initial cessation rate, as defined by at least 1 day of abstinence during the first 7 days of quitting, is about 87.7% on placebo. If you didn't use anything, was 69.4%. But if you used a patch with the lozenge, in an ideal situation, 91.5%. And then they actually brought this study out to a 6-month period. Patch alone was at 34.4. Patch plus lozenge, you were still at 40.1%. Placebo was only at 22. So if you use the patch plus the lozenge for breakthrough cravings, we're looking at about a 6% increase in quit rates. And that's statistically significant, and seems like the best method to use at this point. So right here is the final product of our UPH nicotine withdrawal protocol. There's a section here for nursing care to monitor, and for withdrawal, this is the important part here. We have the patch. We have it based on weight because we don't have cotinine as one of the levels we can get. And then there was a decision between gum versus lozenges, and there was a cost restriction. So we're using patch with gum in this instance. So this is the protocol that we're using for this research study. And then we had to find a way to monitor withdrawal symptoms. So there are a number of nicotine withdrawal scales out there. There are probably about 5 of them. And we chose the Minnesota nicotine withdrawal scale, mainly due to its sensitivity, specificity, and objective and subjective monitoring components of the scale. So and it's very easy to do. Another one of the issues we had was the amount of time that nursing staff could administer this scale effectively. Since they're all short on time, we couldn't go through a complex 50-question withdrawal scale. So this is a pretty straightforward one. It's about 9 questions. And this scale is, I guess there was some negotiation on the amount of time the scale should be administered. Usually, in ideal situations, every 4 hours to monitor nicotine withdrawal. But I guess with the staff restraints, we were only able to apply this scale every shift. And in the scale, it does ask about anger, irritability, anxiousness, mood, concentration, restlessness, and it's both subjective, what the patient tells us, and it's also objectively rated and logged also. Okay, so now we're looking at how we're going to monitor aggression. I guess there are a lot of components that go into aggression. It could be a component of withdrawal. It could be psychosis that goes into aggression. So we just wanted to get an overall idea of how we can measure aggression. So one of the scales out there is the modified overt aggression scale, validated for use in the study of aggression in the developed world. In this study, they had 40 aggressive psychiatric patients and 40 non-aggressive healthy patients randomly selected for the study. The results say that in both male had a higher mean global weighted score than the female population, and the difference was statistically significant. And as the conclusion, it's found that the modified overt aggression scale is a valid instrument for the study of aggression. So this is one that we decided to use once a shift in this study. Okay. So let's take a look at what kind of data points we're looking to monitor here. We wanted to improve the treatment, and we wanted to have better dosing, decrease the amount of nicotine withdrawal, decrease agitation, and hopefully decrease cost here. So on the front end, we wanted to present the patient with the option of the existing versus the new nicotine withdrawal protocol. So this way we can monitor baseline smoking habits, attitude, efficacy. We wanted better dosing, so we can actually monitor the number of nicotine patches that go out. We can also monitor the number of pieces of gum that go out and calculate cost, see if the old method we're using more or less nicotine replacement products on the hospital units. So we're going to be measuring that. We're also going to be measuring their nicotine withdrawal symptoms, and that's by the Minnesota nicotine withdrawal scale. So this is something that we'll do per shift, and we can actually compare numbers to see if the control group versus the experimental group have higher or lower numbers. And then we're also monitoring the agitation, which is what we're interested in this study. And then we're going to do that by the overt aggression scale, nursing assessment, nursing reports, the amount of drugs that are used for seclusion and restraints, may they be Purine, Ativan, Purine, Haldol, to control those aggressive behaviors, number of security calls, and calculate the cost of those elements. And hopefully we get the end result where we are decreasing costs, increasing patient comfort, change in attitude, and we also wanted to monitor this also, and that's through our post-hospitalization patient survey. So this is just a brief overview of what the last slide just said. So a patient is admitted, the number of patches are monitored, and the number of pieces of gum are monitored. We come up with a cost. The application of the withdrawal scale for both groups and the comparison between the two are done. We continue to monitor for aggression in both groups every 8 hours. We monitor the number of seclusion and restraints and correlate that to the cost of the medications needed and the cost of security coming up onto the units. And then we're going to continue with the application of the aggression scale. And then we're going to have a post-hospitalization satisfaction survey and the possibility of quitting with appropriate follow-up. And these will be a 10-question survey for the patients to fill out when they are discharged. So there'll be a scale to determine their level of motivation for quitting between the control and the experimental group. And then we also will provide follow-up services and continued medication support. Okay. And some of the most important things in this patient satisfaction scale is to remember our 5 A's. And there have been quite a few studies that have been done based on the 5 A's, and it's actually been shown that it's 50% more likely that a patient will quit smoking if they're asked by a healthcare professional or a physician. So right there, if you just asked about the 5 A's, you increase their probability of quitting by 50% immediately. So what we do is we ask, identify any tobacco user, ask on every visit if they're using any tobacco products. You advise, so you urge all smokers to quit. And you always can use it as something customized to their situation, like if they have COPD, lung cancer, you can say, well, it could definitely help improve your health at this point, so I strongly advise you to quit. So just customize it, ask if he or she is willing to make a quit attempt at this time, and then you assist in helping them quit smoking, and provide options. May they be medications, or there are quite a number of hotlines also, and you arrange follow-up. Okay, so on this study, one of the things we wanted to do was find some certain correlations in the amount of data that we're going to gather. So we're going to try to have see if there is a correlation, statistical correlation of nicotine, between the nicotine withdrawal, severity of it, and increase in aggression or aggression on the unit. So hopefully there will be a strong correlation between those two data sets. And then we also were looking at the statistical correlation of nicotine withdrawal management versus quit rates. I think the second one is something that we wanted to maybe a phase 2 project where we're looking at application of the new nicotine withdrawal protocol, which will eventually help with increasing quit rates when discharged from the hospital. I think that's our main goal in all of this. But we're going to start with the top one first. And then I guess we're also going to be using this nicotine withdrawal protocol to improve overall quit rates at the hospital. There are a number of national hotlines out there that are helpful for post-discharge. One is the Arizona Smoking Hotline. That's a 24-hour hotline available here in Arizona, and they have counselors available to help anybody that needs to quit, and the number is there. And there's also the National Smoking Quit Line, which is available to anyone. That's the 1-800-QUIT-NOW. So where are we at in this study at this point? I guess the question, and everybody's wanting to know what the answer to all the data is. But we're still in the process of completing the study. We do have, at this point, we do have the nicotine withdrawal protocol implemented. It is available at our hospital for physicians to use. So that's been the bulk of the progress we've made over the past year. But I think over the next couple of months, we're actually going to start interviewing patients and giving them the option to participate in this study. So any help, if anybody's interested in helping out, we're also very interested in research assistance, anybody that can consent to grab the data for us. So that's where we're at this point. So this will be a to be continued presentation. Okay, so I'll just open up the floor for questions. Yes, Dr. Harris.
Thank you.